Hi guys, welcome back. We shall now be discussing regarding fat embolism syndrome. The clinical question that has been asked or will be given to you will be on similar lines to what I'm discussing. For example, I'm describing a 18-year-old boy. He was driving a Harley Davidson bike, like he bought a heavy duty bike. It could be Harley Davidson or maybe Bullet or anything. And while he was taking a sharp turn, the bike skidded and fell on the leg of this guy, causing a fracture of the femur. So most of the time, in questions of fat embolism, there will always be a definitive history given of a trauma slash polytrauma. Like in this case, I said the chap had a biking accident. He was luckily wearing a helmet, like Harley Davidson or all these good brands will provide a good helmet. So though his head slammed against the road, luckily for this guy there was no concussion, there was no unconsciousness, there was no CNS bleed in this patient thanks to the helmet that he was using. But the bad news is that the bike fell on the leg of this guy, resulting in a fracture of the shaft of the femur, and he had to be rushed to the nearest hospital. The opening line of the question talks about polytrauma. You should be open towards possibility of fat embolism syndrome in a patient. Let us now see what the question will say, and I'll provide reasons for the same also, that why would this be happening. But what you will notice in all clinical based questions, which would span over 2-3 lines, will be the following words. One would be that he has been rushed to the nearest orthopedic hospital where the best orthopedician has operated on this guy. He has been treated by the best surgeon, but after 12 to 24 hours post surgery, so I'm just writing the word post operatively in these patients. In fact, the symptoms we really can't predict. They are developing anytime between right on the first day after surgery to maybe on the third day. There is a development of sudden onset breathlessness in the patient. I mean, this guy was okay when he came out of anesthesia. He was fine. He even talked to his mom and dad, and he could recognize his mom and dad. He smiled at his mom and dad, and they were relieved that he has been treated at a good hospital by a good orthopedic surgeon, and he will recover. And then, to the surprise of both the orthopedician, the physician on duty in the intensive care unit, and parents, there is a sudden onset breathlessness in this patient. Along with this, he might very fast progress into stupor or coma. So, I mean, this stupor and coma is not related to any CNS problem that this chap is having. I mean, he did not have any extradural, subdural, subarachnoid hemorrhage, but it was a cognition defect that has occurred in this patient. And apart from this, there is a very characteristic feature of petechiae that develops in this condition, because the fat globules embolize into the systemic circulation, and then they set up an inflammatory response. And the cytokines which are produced in response to this inflammatory response, they can cause development of petechiae in the patient, which could be, first starting in the axilla and then spreading to the rest of the body of the patient. So the message is, though I'll give you explanations for each of these manifestations, I mean, whenever you're gonna read a question like this, where you are having a history of a trauma followed by sudden onset breathlessness, a cognition defect, and a petechiae, you have to think in terms of fat embolism syndrome in a patient. Now, why am I not thinking in terms of possibly a pulmonary embolism in a patient? Because in pulmonary embolism, usually we don't read about petechiae, we don't read about a cognition defect in a patient, and most of the time, a person should be having a predisposition for development of pulmonary embolism. I mean, he should be having a hypercoagulable state. So suppose this guy was immobilized for a relatively longer duration, and then subsequently there was formation of clots in the legs of this guy, and there was a visible swelling in the leg of this person, following which the clot embolized. We could have thought in terms of pulmonary embolism. We will anyway be doing a CT pulmonary angiography to differentiate between fat embolism and pulmonary thromboembolism. So that would come in the workup. But basically, my first objective in the first 5 minutes of the discussion was just to sensitize you to the fact that fat embolism should always be kept in mind when you are dealing with a question which you think that looks like pulmonary embolism. Because in pulmonary embolism or thromboembolism also, I have described almost similar kind of profile. Post-operative patient, second day, third day, sudden onset respiratory distress. And here also I'm describing the same thing only, but there are tinge of differences. What are the differences? I'm talking about mainly a fracture of the long bone, whereas in pulmonary thromboembolism there may not be a fracture of the long bone, but it could be immobilization after GI surgery, immobilization after cesarean section, immobilization due to, let me say, fracture or fracture of the tibia of a person, or fracture of the calcaneum of the person. Both calcanea were fractured when this person was jumping from a height, and therefore the person is immobilized. So my point is that you have to take up the question in the clinical domain and then try to evaluate the possibilities. Pulmonary thromboembolism is always more common than fat embolism. So our objective now would be that what would be the special features of fat embolism that would, alert you, though I have mentioned a few of them like cognition defect, petechiae, but there would always be circumstantial evidence given in the question. So we need to understand the pathophysiology behind the development of the disease. Let me symbolically represent this as shaft of the long bone. I've just shown that it is fractured. There's a twisted fracture, and the fat globules have come in the blood circulation of the patient. The moment they come into circulation, the enzyme by the name of lipoprotein lipase will now start showing its effect, and therefore it will cause generation of free fatty acids. Please appreciate that in our body, fat does not travel free. I mean, fat is always going to be traveling in the form of lipoproteins. But here, there is free fat in the circulation. It's acted upon by lipoprotein lipase to generate free fatty acids. And these free fatty acids are the villains which contribute to development or damage to the pulmonary circulation of the patient, which explains the respiratory distress that develops in the patient. Obviously, there would also be production of inflammatory process contributing to cytokine production like interleukin 1, etc., which will contribute to problems. But the villains in this condition initially are free fatty acids in the circulation. The free fatty acid component has been documented to cause structural damage to the pulmonary circulation, especially the pulmonary endothelium, and the end result would be ventilation perfusion imbalance, because you see the blood vessels of the lungs are getting damaged. So there's a ventilation perfusion imbalance or respiratory distress developing in a patient, and radiological features will also develop in the patient. At this junction, I would like to just say a random fact before you. When it comes to orthopedic procedures like intramedullary nailing, then it has been documented in clinical studies that post intramedullary nailing also, because you're hammering into the bone, there is always a development of release of fat emboli into the circulation, but the amount is very less. So most of the time it's cleared by the body's inbuilt system, and therefore we can have asymptomatic fat embolism syndrome also. And usually, I mean, orthopedic procedures which involve a bit of, I would say, hammering into the bone can contribute to fat embolism, but it will not cause substantial disability to the patient because the body will handle limited amount of fat globules in the circulation. On the contrary, if there are certain triggers which are given in the question in the form of polytrauma, like I explained to you, it could be fracture of both the shaft of the femur or one shaft of femur, but long bone trauma has to be given. There's a possibility in the question that he may not give you polytrauma, but might describe a patient of acute pancreatitis. So fat embolism has also been documented in conditions beyond only fracture of the long bones. Like, he might talk about joint reconstruction surgery. This person is an old man. He uses steroids as an Ayurvedic supplement. He doesn't know that he's taking steroids, but he thinks it's Ayurvedic supplement that can cause avascular necrosis of the hip joint. And post joint reconstruction surgery, there is a possibility of fat embolism in the patient. Though I would also like to tell you that the bone cement that is used during joint reconstruction surgery in old people, that bone cement can also embolize into lungs. That is also a possibility. Then pulmonary thromboembolism is anyway a risk because the person will be lying in the bed. So you have to keep your mind open for cement embolism, bone cement embolism versus pulmonary thromboembolism versus fat embolism in a patient. And I will teach you diagnostic criteria by which you have to apply in the clinical based question so that you are able to identify whether fat embolism is present. Studies have shown that even people who are undergoing liposuction procedure, it's a cosmetic procedure, it's a very simple procedure, but studies have shown that people who have undergone this cosmetic surgery have also ending up with fat embolism. Then people who are on total parenteral nutrition, TPN, like a patient of extensive bones or massive GI surgery, the person is on TPN, total parenteral nutrition, then IV fat infusions have also been documented to contribute to fat embolism syndrome in a patient. Last but not the least, decompression sickness, that is also called as Kaison's disease. This would be rather more being oriented towards, I would say, when a diver will come up from, let me say, 200 meters below the surface, then sudden ascent of the diver can contribute to gases to expand, especially nitrogen. So nitrogen bubbles can be formed in the bloodstream and they can cause Kaison's disease. Studies have shown that in decompression sickness, which is also called as Kaison's disease, you can not only be having nitrogen gases contributing to symptoms, but even fat embolism has been documented. So these are some of the important causes why would you be getting fat embolism syndrome, out of which majority of cases would be answered by you as, or the most common cause would be answered by you as trauma. In fact, here I would like to quote the textbook by telling you the fact that he has mentioned that in cases of polytrauma, where long bones are also involved, the incidence of fat embolism approaches to the tune of about 90%. Now that is a substantially big figure, no? 90% percentage of fat embolism. And then he adds another statement. He says incidence of fat embolism syndrome is only 2% in cases where there is a fracture of the long bones. Why I'm telling you this data is to make you understand that not all cases who are having fat embolism will end up with clinical symptoms. Most of the time, our inbuilt, I would say, body defense systems will neutralize this fat, the cytokines, and therefore there would be very minimal findings in a person, or those minimal findings might be masked by the intracranial illness of the person because he has had a substantial injury to his body. So we might be thinking that his manifestations that are developing are a part of actual illness that he has suffered. So it requires a high index of suspicion for you to understand that the features of fat embolism syndrome will be over and above whatever injuries that he has sustained. I mean, suppose he went into shock, so the features that will occur in fat embolism will be over and above the type of shock that the person has suffered from. So let's have a look at the major criteria for identification of fat embolism in a patient. First of all, you should be having a respiratory involvement in the patient. The respiratory involvement will be in the form of sudden onset breathlessness. Like this person, he was operated in the best orthopedic hospital day before yesterday, and today afternoon he started having sudden onset breathlessness. So the nurse called up the orthopedician. He said, "Sir, this patient you operated yesterday, he's having breathlessness." So he said, "Okay, I'm in the OT. I'll come after 1 hour." But by that 1 hour, the things might deteriorate so fast that the orthopedician will be at loss of words to explain to the relatives why suddenly something happened, and he would not do any action, because I want to tell you that there is no system by which we can predict fat embolism. Fat embolism, when it occurs very suddenly, right? I mean, if this happens in career of any doctor, even if you're running a nursing home, you're not directly handling trauma, you are the boss, people might come to you and ask you, "Doctor, why in your hospital suddenly somebody is deteriorating?" You would not have the capacity to explain to these non-medical people why there's a sudden deterioration, because fat embolism, when it happens, it's suddenly the emboli will disseminate to brain also. And if fat emboli will go and affect the brain circulation, cognition defects will come, stupor will develop, coma will come, and there's no treatment for it. So respiratory wise, there should be development of symptoms in a patient. There should be respiratory insufficiency manifestations in a patient in the form of fast breathing, accessory muscles of respiration being used in a patient, and even radiological evidence can be developing in these patients in the form of diffuse infiltrates, which you might think as ARDS, but then ARDS, or acute respiratory distress syndrome, has multiple other features which will not be present here. Like, there would always be a CNS malfunction occurring in this person. There would be a cerebral sequelae developing in a patient. This could range from milder things like cognition defect to severe impact like stupor and frank coma in a patient. Coma is defined as Glasgow coma scale values less than 8, and this will happen very fast. You will also notice patient having development of petechiae. Most of them first appear around the axilla. They can develop subsequently across any part of the body. They can even be found in the subconjunctival area. But you don't read about petechiae in ARDS, and usually you don't read about ARDS person straight away going into coma. So these features that I'm explaining to you at the moment are called as major criteria for diagnosis of fat embolism in a patient. There should be respiratory involvement or a CNS involvement and presence of petechiae in a patient. So these features, if they're present post trauma, post fracture of the long bone, you have to think in terms of fat embolism syndrome as a possibility. Coming to the minor criteria for diagnosis of fat embolism in a patient, you will be having a tachycardia with hyperthermia. This is explained by liberation of interleukin-1. Remember, I said cytokines are liberated once the fat globules come in the circulation. So they would be resetting the temperature of the hypothalamus, and therefore person would be burning hot. He's having breathlessness. He's not recognizing his mom and dad. And like 5 hours ago, 4 hours ago, he was just fine. He was maybe fiddling around with his smartphone, maybe updated his Facebook status that, I had an accident on my bike, and then he maybe loaded a picture of his crashed bike, as young chaps now do just to show off to his friends on his Instagram and Facebook. And now this guy is not recognizing his family members. He's burning hot at this point of time. When you will do a fundus examination in this semi-comatose or comatose person, you will notice that he would be having retinal changes. That is, the fat globules will be blocking the microcirculation, as well as the main retinal arteries might be having a break in the column due to fat globules which are stuck there. The kidney circulation will be affected, so there could be a deranged kidney function test. the liver circulation will be affected. So if you open the eyes of this comatose patient, is lying with his eyes closed, you might be able to notice that the sclera of the person is relatively yellow. The sixth manifestation is explained by cytokines as well as activation of the complement system, which can result in drastic fall in the hemoglobin as well as platelet count of the person, which explains the petechiae that develop in this condition. Because there's an inflammatory state, so ESR will begin to rise. The low hemoglobin and the low platelet count is explained by the cytokine and the complement system activation, which attacks self-red blood cells. Seventh feature in the patient would be fat microglobinemia. This can be demonstrated in the urine of the patient as well as in the sputum. It looks very surprising to read this statement, no, that I'm saying urine having fat globules, sputum having fat globules. That is not something very routine, and therefore it is one of the diagnostic features of this condition. For fat globules in the urine, however, I would like you to remember that alternative name for fat globules in the urine is oval fat bodies. You will read this in the literature of nephrotic syndrome. So when you go through the kidney section, nephrotic syndrome, that's where you would find this. Another area where you will find fat globules in the urine can be parasitic infestation with filariasis, that is chyluria. So three conditions where fat globules in the urine could be there is fat embolism syndrome, nephrotic syndrome, and chyluria. Why, you can understand now why point number 7 is minor criteria, because it can be seen in other conditions also. So let's just recap. You could be having CNS involvement, lung involvement, and petechiae in a person. Along with this, you could be having these minor manifestations that I have said. So all these descriptions that are given you on the previous two slides are technically called as GERD criteria for diagnosis of fat embolism in a patient. There should be at least one major criteria being satisfied. Either the person is stuporous or he is having breathlessness, petechiae present. So one major criteria should be satisfied in a patient along with 4 minor criteria, and you are bang on target to identify fat embolism syndrome in a patient. Therefore, if I go back to the opening slide of this discussion, that is what I was trying to explain, that there was all the characteristic features that were developing in this person. I had in the starting of the question not talk about vitals, etc., because that would have eaten a precious time. But you can notice there is a lung involvement, there is a CNS involvement, there is a petechiae in the patient. So 3 major criteria are already present, whereas for diagnosis we need at least 1 major and 4 minor. Here already 3 major are present. So you already know that the diagnosis of the patient is fat embolism syndrome. Coming to the workup of patients of fat embolism syndrome, the first investigation to be done is a chest x-ray, and simultaneously I can do a arterial blood gas analysis to look at the oxygen status of the patient. The chest x-ray of these patients in early part of the illness will be normal, but subsequently it is always going to reveal bilateral diffuse infiltrates. In majority of MCQs that are given in the exam, they will deliberately write bilateral diffuse infiltrates visualized in the x-ray post-trauma. Why he wants to do that is because he wants you to have double thoughts regarding answering fat embolism, because ARDS also has bilateral diffuse infiltrates. But clinical history will make it clear, because swine flu is one of the important causes for ARDS. Sepsis can trigger ARDS. Multiple blood transfusion, that is TRALI, transfusion related acute lung injury, can contribute to acute respiratory distress syndrome. So the causes of the clinical scenario will be different from what we are talking, where there's a post-operative patient who has had sustained multiple orthopedic trauma and then is suddenly deteriorating. So there is a high probability that he will give bilateral diffuse infiltrates, but you have to look at the logic and then work out the question. The second investigation I will do in this person will be a CT head. Why? Because there is a sudden onset neurological deterioration. Thankfully, in this person, the CT head is normal because there is no subdural or extradural hemorrhage. Still, there is a deterioration. If we repeat the CT in the same patient again, there might be visualization of diffuse white matter petechial hemorrhages. They may be seen, they may not be seen. It depends on the experience of the radiologist. Like in the casualty, lots of time first year junior resident JR1 will be on duty. So JR resident 1 may not be skilled enough to pick up this white matter petechiae, and therefore I'm writing it as plus minus because they are there but they may not be visualized. We will therefore not use, or rather be dependent on the skill of the doctor. We will rely on the criteria that I was talking about, GERD criteria. And you would have noticed that CT was not included in the GERD criteria primarily because of the normal findings which could be present, and normal cannot be called as a diagnostic criteria. We will also be doing a transesophageal echo in the patient. Why? Because you will notice that the fat globules came in the right side of the heart. Now they will go in the lungs. But how is it that the person is having cerebral manifestations? It is not that the fat globules will first go to right side of the heart, then go to lungs, from lungs they will then come to left side of the heart. I mean, it's not possible for fat globules to travel like this. So how is it possible that CNS manifestations are occurring? Could be a viva question for you, in fact, and you as a doctor should think that, I mean, after all, fat has gone to right side. Why are the symptoms seen of cerebral embolism? That's because some patients could be having patent fossa ovalis. In fact, the incidence of this has been found for this particular condition, that is fat embolism syndrome cases. PFO has been found to be documented in about 20 to 30% cases. That's very substantial, and this explains why that left-sided features or the fat globules go to left side via the patent fossa ovalis. It's a right to left-sided shunt. It operates opposite to a AST, and therefore, you would have read a term paradoxical embolism. That's the same PFO. No, patent fossa ovalis causes a development of paradoxical embolism because deep vein thrombus, they come to right atria, then can go to left atria, then into systemic circulation. Here it is fat globules and the cytokines which come in the right side, then go to the left side and into the brain circulation of the patient. Transesophageal echocardiography may not be routinely available, at least in emergency. So point number 3 is mainly of academic interest. I would also like to do a Doppler of the legs of the person, because if the person is immobilized, there is a possibility that clot formation may have occurred. So Doppler of the leg circulation would be done to rule out deep vein thrombosis in a patient, that is involvement of soleal vein, popliteal vein, and that can help us rule out possibility of thromboembolism in a patient. The fifth investigation that I will be doing in this condition is mainly done for academic interest, that is bronchoalveolar lavage with staining for fat. Do remember the fact that this investigation 3 and 5 are mainly done in research-based institutions, but 1, 2 and 4 should definitely be done to rule out other causes contributing to sudden onset breathlessness in this individual. For management of patients of fat embolism syndrome, we shall be doing the following steps. 1, we will initially provide high flow oxygen to this patient. This would be given at about 12 liters per minute. If he is not maintaining his oxygen saturation, we will have to intubate the patient electively and then put him on positive pressure ventilation. Now, before I intubate the patient, I must always ensure that the hydration of the patient is proper, because these patients are breathing very fast. So there is a lot of water loss from the body due to fast breathing. There are increased insensible losses. So because most of these patients are having substantial amount of dehydration, which is due to 2 reasons. 1, there is a stress or medical illness. Second is breathing fast, so insensible losses are present. She says load the patient with fluids and maintain good pulses, so that when you intubate, you might have to give drugs that sedate the patient, and most of the time the drugs that are given to sedate the patient before elective intubation, they can cause vasodilation and a drop in the blood pressure. So he says load the patient with fluids, intubate, and then start the person on positive pressure ventilation. There is no treatment choice for this condition. Steroids have been given for reducing the cerebral edema component that develops in these patients. Heparin injections have been given for very surprising fact. Please appreciate, heparin here is not given for treatment of any clots, because there are no clots in the circulation, but heparin has an anti-lipemic effect. That is what KDT says, pharmacology. It says that it has an anti-lipemic effect. It dissolves away the fat globules, so the burden or the load of the disease would be substantially reduced. So 2 messages that I want to give to the end of this discussion is: 1, that there is no investigational choice of this condition. It is based on word criteria. There is no treatment of choice for this particular condition, and the supportive treatment in this patient would be to mainly prevent deep vein thrombosis. So I might have to give elastic compression stockings which are powered by air pump, and similarly they can have stress GI bleeds. So pantoprazole can be started, because they are going to remain in the intensive care unit for multiple number of days. Recovery is definitely possible. The mortality rate of fat embolism, if identified on time, is less than 10%. But he's written this word: if identified on time, the mortality rate is less than 10%. In our hospitals, the mortality rates in India especially are much higher, because this condition is usually not recognized. Why? Because we might think that this breathlessness and CNS depression of the patient is a part of the original injury that he has suffered, whereas this is a separate medical illness in the patient. That is why these words that I've said right in the beginning of the discussion are of importance. If you read a person who has been treated for polytrauma and then there is a deterioration 12 to 72 hours later with the words written like sudden onset breathlessness, cognition defects, stupor, coma, petechia described in a question, you should think in terms of the topic that we've started, which is FES, fat embolism syndrome. I repeat my statement, lots of cases will have fat embolism, but it will mostly remain asymptomatic. Our body has great powers of healing. But if the critical amount of fat, and they have not been able to determine what is that critical amount of fat globules coming in circulation beyond which all these problems will occur. This is the reason why we don't have any scoring pattern by which we can predict fat embolism. Like there's no case where we will say, okay, this one fracture, fat embolism will occur. This much percentage chances, two fractures of long bones like bilateral humerus fractured, this much percentage bilateral humerus with bilateral tibia and bilateral femur shattered, like 6 long bones shattered, then this much percentage of fat embolism. That we have not been able to do. So because the predictive systems are not in place, that is why we are having a exceptionally high mortality for this condition. So these are the details which are important, especially the GERD criteria. If you go through them just once by writing, I think you would be able to perform better. And the message is, why I said writing is because writing and you listening to me, that is audio, you are looking at me and seeing the screen while I'm writing, that is visual, and then handwritten, the visual memory will improve even further. So wherever possible, the topics which are usually asked, like fat embolism, every time NEET there will be a question on fat embolism syndrome. This time 2020 there was a question whether you include that in orthopedics or medicine, that prerogative I would say, but do appreciate the fact that there are some questions which are always going to be asked in the exam, like FES, ARDS, they are like like bread and butter for you. So when you are listening to these lectures, especially, I would like you to make your handwritten notes at least for these topics, so that the visual memory of your handwritten notes would also come in handy for you. And if you perform ABG in these patients early on, they could be respiratory alkalosis due to carbon dioxide washout. And if the damage to the pulmonary endothelium is substantial, then ventilation perfusion imbalance will settle. So carbon dioxide levels will begin to rise. So PCO2 values in lung diseases can fluctuate depending upon initial and a later profile. So person could initially have respiratory alkalosis due to hyperventilation, deteriorates into then development of respiratory acidosis also. So similarly in asthma, early part of asthma, there is fast breathing respiratory alkalosis. In imminent respiratory arrest, there is a carbon dioxide buildup, so there is a respiratory acidosis in the patient. Unlike in metabolic causes, you can't have this swap, acidosis getting converted into alkalosis. But in respiratory, I think you notice that fast breathing initially, respiratory alkalosis due to carbon dioxide washout. Same person of asthma, later on in imminent respiratory arrest, there is a type 2 respiratory failure and a respiratory acidosis developing in a patient. So I would also like you to listen to the lecture of respiratory failure that I've discussed, so that these terms would become relatively more clear to you. So thank you so much for your patience and listening to me, and keep the focus on, and you guys are brilliant chaps. You will do very great in the exams. Thank you.